Okay, folks, if you're viewing this, I'm sorry I missed the session today, but today we're going to be talking about principles of pharmacology and how it pertains to the medical assistant. This is probably one of your most important lessons because when we're talking about pharmacology, we're talking about the studies and the properties of all drugs and medications. Now, that's not to say that you need to memorize whatever medications are out there because it's just impossible. But when we talked about medication errors, that are one of the never events that should happen in medicine. We have to be very, very responsible when it comes to how we handle, how we administer, how we store, and how we educate our patients about various drugs and the medications they use. So let's start off with the question and answer. The study of properties, actions, and the use of drugs is actually the term pharmacology. The study of drugs and their uses. Okay, the properties. Okay, what they are made for, their actions, how do they work? The uses, what are we using them for? A drug is basically a chemical substance used to cure, treat, prevent, or diagnose disease. So an antibiotic, for example, will be used to cure a respiratory infection like pneumonia. Some drugs don't always cure diseases, but they treat, such as insulin, which treats diabetes, does not cure it. Medication to prevent illnesses like vaccinations. Sometimes some medications can help us diagnose a disease as well. We give a particular type of medication that is injected into the hormonal system and you elicit a certain response, we might be able to see if there's certain hormonal, like adrenaline insufficiency or other type of situations may be developing. New medications are continually being developed, so it's impossible to memorize every single drug on the market. It's just not going to happen. So let's look at this next question. Which of the following is a source of drugs? And if you pick all of the above correct, you are right. So all the following are sources of drugs. Plants, for example. Maybe we think of some of the more common plant type drugs out there like marijuana, but actually there are drugs like digitalis, which has been around for centuries, made out of the foxglove plant. Animals, believe it or not, yes, I mean, as cruel as that may sound, things like insulin are made from cows and pigs. Minerals, such as magnesium and calcium, these are all mineral-based drugs that have certain effects on the body. Microbiological sources. So a lot of times the way we make things like vaccinations is that we use microbiological enhancers to duplicate them. So they're all correct. So, and just what you sort of see right there. So a plant source, animal source, mineral source. And not to forget that many drugs are made chemically and synthetically in the lab, which can have some advantages. Cheaper to distribute, easier to obtain, less adverse effects, which we'll talk about in a few moments. So what are some of the common uses of drugs? And of course, when we say drugs, we, for our purposes, refer to medications. Well, certain medications and drugs are used to prevent disease, like, as we mentioned before, vaccinations, vitamin supplements, treatment of diseases, whether it be curative or just palliative or just to maintain overall health. Drugs can be used to diagnose particular diseases. Of course, we talked about cure as well. Contraceptive, to prevent pregnancy. Health maintenance, so things like to maintain cholesterol levels, diabetes levels, blood pressure levels. Palliative means to comfort. Usually when we refer to palliative care, we refer to things such as end-of-life care. Replacement. So there's sometimes when our body is not making enough of a substance, so we need to replace that substance. If you have a hypothyroid condition, you need to replace that thyroid hormone from the outside. If you have diabetes type 1 and you're not making insulin, you need to be given insulin from the outside. So the study of drugs, absorption, distribution, metabolism, and excretion in the body is known as pharmacokinetics. Now, if you look at the suffix of that word kinetics, like kinesiology, how things move, then you can understand that pharmacokinetics is the way how drugs are moved throughout the body, how they're taken in, how they're absorbed either through the GI tract, the skin, or whatever other means possible, how they get to the sites where they're needed to get to, whether it be to a gland, a nerve, the brain, the heart, how that organ or how that tissue actually works with it or metabolizes, and ultimately how it gets rid of it from the body. How do drugs enter your body? Number of different ways. So we commonly know about ingesting pills. That's the most common way uh, drugs are entered the body, but there are many, many other different ways that we can get medications into the body. Some practical, some not so practical, some quicker, and some easier than others. So the most common way they're taken is usually by mouth or by ingestion, or how we would abbreviate PO, per os. Implanted medications, implanted pumps, such as an infusion pump, may give a person a certain amount of medication over a set period of time. For example, if you're coming off a very painful surgery, sometimes patients are hooked up to pain relief pumps where they're actually allowed to give themselves extra doses of pain medication within limits. Medications can be distributed or absorbed by inhalation through the respiratory route. A very common example is general anesthesia, but there's other medications as well. Things like nebulizer pumps, for example. Injection. I'm sure everybody's had a flu shot or a vaccination or maybe just a shot of something to relieve pain, where it goes deep either into the muscle or to the subcutaneous layer of the skin and then gets slowly distributed into the bloodstream. Patches and topical applications are a means of providing medication, what we call transdermally or through the skin. A fentanyl patch for end-of-life care, very powerful pain-relieving medication, and all sorts of other like numbing patches that some of you get over the counter, some of you may get by prescription. So when we look at the principle of pharmacokinetics again, ADME, absorption, how will it get in? Well, we just described most of those. Um, Distribution, where will it go? Well, first place it goes is in the stomach, if it's orally ingested. Then when a drug goes into the stomach, into the digestive system, most of it gets transported to the liver. Now where it gets processed and some of it gets broken down and reconverted. If we want to bypass that whole system and get that drug working faster, like we might in emergency medicine, we would go via what we call the parenteral route, along or aside from the enteral route, which means by the digestive system. So a drug that's given intravenously or even intramuscularly will not have to take time to be processed or metabolized in the liver before it takes effect. So even though oral medication use is the most common, most easy way to deliver medication, it's also probably the slowest way to get it as well. And then ultimately, whatever we don't use, we want to get rid of. Most of the medications in our body is excreted either through the urinary system or through the feces, primarily through the kidneys and the urinary system. So the means by which a drug enters the body, the site of administration, is the route. Is it the oral route, the subcutaneous route, the inhalation route? And again, we just pretty much went over how these things are administered. Oral inhalation, sublingual is another way to administer medications. For example, a nitroglycerin pill goes under the tongue, it gets dissolved. It's a very common anti-nausea medication called Zofran. It goes under the tongue, doesn't get swallowed, because what's the point of giving a medication for nausea if a person keeps throwing it up? And then please be aware of the term parenteral. Intravenous, the medication goes directly into the vein. Intramuscular gets injected into the muscle, and subcutaneous, where it goes into the skin, the fatty layer of the skin. Some medications, like suppositories, are introduced through the rectal route, especially in young children. You can't really see that word right there, but another way that medications can be introduced is through intrathecal. It's through the spinal cord, the spinal canal. Intraosseous is used in emergency medicine for someone who's really in critical condition. That's when they stick a needle directly into the long bone of the body. And medication is infused through the bone marrow and ultimately gets distributed into the bloodstream. If you all are wondering what that hacking and gacking in the background is, that's my pug chewing on a bone and probably trying to bite off more than she can chew. Pug is very close to pig, and sometimes she acts like one. So let's talk about drug actions. Well, they can slow down a cell's activity or have a depressing action for that. Something like a beta blocker would slow down the heart. It would slow down transmission through the cardiac conduction system. And on the opposite side, it can have a stimulating effect. Probably my favorite stimulant drug is caffeine. Drugs can destroy cells like chemotherapy agents or disrupt part of cells like antibiotics can help break open the cell membranes of certain bacteria. As we mentioned before, replacing substances that are acquired by the body can be given as medications like thyroid supplements, like electrolyte supplements, like insulin. So most drugs metabolize, now if we listen to me before, in the liver. The liver plays a big part in breaking down a drug once it enters the body, separating it into components by various enzymes, and sometimes releasing the drug as is into the bloodstream, or breaking it down into a byproduct in which the drug can be used. When we talk about how a drug goes from the digestive system into the liver, we call that a first pass metabolism. And then the drug gets circulated around the body, and then it comes back around through that whole circulatory loop, and it gets processed in the liver again, and then processed again. If we really want a quick action and we want to bypass that first pass metabolism, that's when we would go and try to give something parenterally without going through the digestive system, like through injection or IV. And so you can see again right here. Here is a representation of the intestine, the gut wall, the cells, the epithelial lining in between or bordering the intestine, and then the one vein in the body that doesn't actually carry any blood to the heart, called the hepatic portal vein, which carries blood directly from the gut to the liver and then outside the liver, kind of like the shuttle train to Midtown Manhattan. So some factors can influence how a drug works or the action of the work. So environment, for example, physical setting, if hypothermia, hyperthermia, social setting, if a patient doesn't have access to medications, they're not going to work. The type of drug itself. Is it a drug that interacts with other drugs? Is it pure? Is it adulterated? Is it been cut down? How the drug was put into the body, the time the drug was taken. I'm sure many of you had prescriptions and been told you have to take one every 12 hours or every 6 hours, depending on the makeup of the drug. Other factors include age. All right? We got to measure medication dosages in small children by weight. When we have very elderly patients, we got to make sure that they can process and metabolize and eliminate these drugs efficiently. And sometimes they lose the ability to do so. So that would modify the dosage of a drug that we would administer. The therapeutic effect of a drug is the intended action for that medication. So, for example, the therapeutic effect of Advil is to reduce inflammation and then hopefully subsequently reduce pain. Some other side effects would be to reduce fever as well. So, for some medications, providers may prescribe a higher initial dose called a loading dose. Helps a person achieve a therapeutic range sooner. An example of that would be a very common antibiotic called azithromycin, or as you might heard of a Z-Pak. It usually starts with 500 milligrams on day one, and then 250 milligrams for the next 4 days. So they want to give that kind of loading dose to build things up. Now, this is what we really have to look out for, is the adverse reactions. All drugs have side effects, but some of them can be worse than others, such as an allergy. An allergy is the body's way of getting rid of something that does not belong there. The body sees everything as either us or them. It wants to keep us, it wants to reject them. I'm sure from previous talks you all know that anaphylaxis is an allergy in high gear, turbo boosted. That is a severe life-threatening condition. It's an allergic reaction that's gone overboard to the point where now it's constricting a person's airway and breathing and possibly causing their blood pressure to tank. As you can see here, the child on the left is suffering from an anaphylactic reaction. His body's become so allergic to something that all the blood vessels in the face are leaking and pouring fluid out of the spaces, causing his eyes to swell, his face to swell, might start causing the airway to swell, in which case we're very, very worried. And so this can be a typical allergic reaction to a drug. Might not necessarily mean it's anaphylactic though. So you got to look at airway compromise or cardiovascular compromise. You got to look at the cumulative effect of a drug. So over time, drugs may not be eliminated from the system very efficiently. So sometimes therapeutic levels have to be monitored over certain periods of time, like certain blood thinners. And of course, many drugs can have a very toxic level if they're taken above and beyond the dose in which they're supposed to be prescribed. And this is a big problem I see in medications, in that sometimes we don't understand and appreciate that some drugs can interact with others and cause very adverse effects. So if a patient, for example, is taking a common antidepressant like nortriptyline, and they're also put on a common antibiotic like azithromycin, the Z-Pak that we talked about. That can cause a profound disturbance in the cardiac conduction system, which can lead to certain arrhythmias. Those are things we want to watch out for. Things that like reduce pain, like narcotic medications, coupled with antihistamines, like your common Benadryl, can cause a profound sedation. After a while, a person may develop tolerance to certain drugs. In other words, needing more and more of a particular drug to elicit the same effect, because the body tends to downregulate the receptors by which these drugs work upon. In which case that leads to drug dependence. We'll talk a little bit later on about the terms addiction and dependencies. You've probably heard those terms somewhere in the past. They are different terms, though. Dependence and addiction are not the same. So in any event, when you talk about trying to prevent things like addiction and dependency, you should know a little bit about some of the drug legislation in the ambulatory care setting, some of the laws on that have come about over the years. So in ambulatory care environment, medications can be prescribed, administered, and dispensed. So what's the difference? A prescribed medication can only be done by the provider. They either put an order into the electronic health system, or in the old days, they would write it on a piece of paper, give that to the patient. The patient would take that prescription to the pharmacy to get that medication filled with all the directions, the number, the days. Now that's not something a medical assistant obviously can do. However, sometimes, and especially in an urgent care setting, we may want to give a patient their first dose of antibiotic or anti-inflammatory, and under the doctor's order, a medical assistant may grab that medication like ibuprofen or like Tylenol and give the first dose, or even an antibiotic and give the first dose in the urgent care. If I'm working in an urgent care late on a Sunday night, or even a Saturday night, and a patient has something like a really bad urinary tract infection. I know they're not going to be able to get to an open pharmacy where they live anywhere realistically on that Sunday. We may give them 2 or 3 pills to take with them until they can get to the pharmacy, and that's called dispensing medication. So, so what regulates what we can and can do and how drugs are facilitated in the United States all comes from the Federal Drug Administration. And it all started with the Federal Food, Drug, and Cosmetic Act that was drafted in 1938 and has had some tweaks in the legislation over the years. Prior to that, there was really no regulation as to what drugs could go on the market. Anybody could process a medication, maybe put a little corn syrup, a little morphine, shake it up in a bottle, put a nice looking label on it, and sell it, and basically tell you it was good for anything in the world. There was no oversight. So that had really come into play around the late 1930s when a particular antibiotic, or something that was marketed as an antibiotic, had a main ingredient very similar to ethylene glycol, which is commonly used in automobile antifreeze, which is highly toxic. So let's backtrack and take a look and see if we can answer this question. Which statement is not true? So A, the Controlled Substance Act is enforced by the FDA. B, the FDA oversees the safety, effectiveness, security, and quality of drugs. C, the FAERS helps the FDA monitor drugs. D, controlled substances are divided into 5 schedules. And E, Controlled Substances Act is enforced by the FDA and the FAERS helps monitor the drugs. Well, this is not true. The Controlled Substance Act is not enforced by the FDA. The Controlled Substance Act is enforced by the DEA, Drug Enforcement Agency. The FDA is meant to oversee the safety, effectiveness, security, and quality of drugs. And for the most part, safety. Now you have some other substances on the market which are marketed as supplements, and they're not necessarily regulated by the FDA because they're not on record making the claim that they actually cure anything. They kind of circumvent that little legal loophole by saying, well, for example, St. John's wort for many years has been used to alleviate the symptoms of depression. They're not necessarily lying. People have taken St. John's wort for that exact reason, but there's been very little evidence to prove that it actually does that. So they cannot market themselves, or they cannot go on record as saying that we are clinically proven to treat and cure depression. That can be a violation of FDA standards. So the Controlled Substance Act was enacted in 1970 over the Nixon administration. And there's a lot of socio-political banter that can go about as to what led to this act. But it all really kind of kick-started that whole war on drugs situation. But what it was basically meant to do is to categorize most of your recreational drugs that are of common abuse and list them into a number of 5 different categories, Schedule 1 through Schedule 5. Schedule 1, as you can say, no accepted medical use with lack of accepted safety and high abuse potential. Medications within the schedule may not be prescribed, dispensed, or administered for medical use under any circumstances. And some examples of that would be heroin, peyote, ecstasy, LSD, and even marijuana. You say marijuana? Marijuana is legal now. Well, marijuana is legal at the state level, but under federal guidelines, it's still listed as a Schedule 1 medication. Then we go to Schedule 2, which have a little bit better, still high potential for abuse, but accepted medical uses. Schedule 3, and all the way down to Schedule 5, which would be considered the least potentially addicting. So it's important to know standards to be compliant with the Controlled Substances Act as far as storing, maintaining, and securing controlled substances like Percocet, Vicodin, Ativans, whatever controlled substances you may have in your facility. They must be adequately safeguarded under lock and key. Accurate records must be kept, and logs must be reconciled when one medication like this is either used in office or dispensed for whatever reason, because these records do get looked at and they do get evaluated by not only FDA but by the DEA. And if there are discrepancies, there can be criminal investigations that come about from this. And controlled substances that are expired or have outlived their usefulness need to be discarded appropriately, not just tossed in the garbage. Which brings back an interesting situation when we talk about theft and diversion reporting. So drug theft and diversion. There's no secret that there's been a widespread epidemic of opioid abuse and overdose in this country. And when we think of opioid overdose, we commonly think of the stereotypical heroin addict who's sitting in the back of an alley with a needle stuck out of his arm. And to some degree, that's true. But a lot of what kickstarted the high prevalence of opioid use in this country lately was the inappropriate prescribing and diversion of prescription opiates like OxyContins and Percocets. And wouldn't be uncommon for a physician to either overprescribe needlessly for whatever reason, or maybe take a little side money to give a prescription that wasn't really necessary. So the person you see on the left being carried out by federal agents, his name was Dr. Hector Castro. Interestingly enough, I actually worked in the same hospital as him in Cabrini, Lower Manhattan. And I was really shocked to hear this story because he actually taught me a lot about critical care medicine. But some years ago, he ran his own practice in Gramercy Park, and he was arrested, convicted, and found guilty of selling prescriptions for hundreds and hundreds of quantities of controlled substances, and basically selling these prescriptions to anyone who had enough money to buy them, sometimes without even a legitimate physical encounter. And unbeknownst to Dr. Castro was his secretary, whose name escapes me at the moment, who's actually taking his written prescription pads and writing bogus prescriptions and selling them to drug dealers in Pennsylvania at the same time. So you see how this can happen and this isn't happening in some lower socioeconomic area either. This is Gramercy Park, a very hoity-toity, uppity area in Midtown Manhattan. So it can happen anywhere. But don't let yourself be caught up if you happen to notice a situation where this is happening. You may probably think it's time for a break, so why don't you take a quick break before we continue? All right, so let's continue. Of course, there's been a big demand for dietary supplements of all kinds, from anything from ginseng to ginkgo biloba. It's important to refrain from making any recommendations because most dietary supplements may have some legitimacy to them, but they are not regulated by the FDA. The only thing the FDA says about them is they have to be proven to be safe, but they don't necessarily have to prove to actually do anything. So just be careful when patients start asking you about advice about these things. So you need to know a little bit about how drugs are named. So drugs have 3 different names. They have their chemical name, their generic name, and then their trade name. The chemical name is what comes right out of the laboratory. N,4-hydroxyphenolacetamide. Okay, what's the generic name to that? Acetamin. What's the trade name? Tylenol. Tylenol is the brand name that is patented by the company. I think it's Johnson & Johnson, which is very familiar and can only be sold under that package. However, the generic name, the acetamin, acetaminophen is basically a generic brand, and acetaminophen is found in probably 200 or so over-the-counter cough and cold products. If you're looking for just plain Tylenol, and you want to save a couple of bucks, look for the store brand that says acetaminophen. You'll probably get $2 or $3 cheaper than the Tylenol brand. The Tylenol brand is same medicine, but it's owned by the company. So they pay for the name and they pay for the packaging. That's something you may want to discuss with your patients if budget is an issue. So, like I said before, nobody can memorize every single drug that they're going to be using in their practice and every single drug that a patient comes in taking from all the other providers. So we have numerous references by which we can look up a drug's properties, actions, interactions, contraindications, such as probably the most famous one is the physician's desk reference. Websites like Medscape are reputable. You got to look for some that are reputable, some are not. It's never a bad idea to carry maybe a little pocket guide of common drugs, common medications, specifically the ones that are particular to your practice. I'll always respect a doctor who takes the time and says, I've never seen that before, let me look it up, than one that just tries to wing it. So drugs are classified or grouped by how they work. For examples, an anesthetic. Anesthesia basically numbs the area or lessens awareness of pain. An antihistamine is used for primarily allergic reactions. Allergic reactions are caused by the chemical released in the immune system called histamine, which causes the itching and the hives and the teary eyes and the runny nose. An antipsychotic is a medication that's meant for mental health problems to prevent the onset of psychosis or loss of touch with reality. Contraceptives, as we said, are meant to prevent birth from happening or pregnancy from happening. Laxatives to help facilitate bowel movements. A stimulant, for whatever reason, to help amp up primarily the sympathetic nervous system to raise awareness, keep attentiveness, wakefulness, just to name a few. An antihypertensive is to help prevent or bring down a hypertensive situation. An antibiotic is meant to fight off bacterial infections. And there are plenty of other medications as well, antivirals, antidepressants. So drugs are termed by their names, the description. A boxed warning is a really serious warning that has to be put on labeling of this drug if it has a very severe potential side effect. The dosage needs to be explained properly, needs to be carried out properly. The indication is what it's used for. And what about dosing considerations? Well, like I mentioned before, if a patient has a limited ability to metabolize or eliminate a common drug, the dosing may have to be reconsidered. They may have to be given half of the dose instead of the full dose. Or if it's a child, that dosing usually needs to be weight-based. How is it supplied? Is it supplied in pill form, capsule form, liquid form, suspension form, and then how is it administered, which we talked about already. Some other terms that you might want to familiarize yourself with. The side effects. What are side effects? Well, side effects are the effects of a medication that occur in addition to the intended effects you want it to have. Take a common drug like Benadryl, for example. Benadryl would be taken to alleviate the signs of allergic reaction, runny nose, sniffling, watery eyes, itchiness, but it also has side effects as well. Sometimes, for the most part, fatigue, somnolence. Sometimes it can cause a little drowsiness, can also cause a little bit of a dry mouth. Sometimes it can cause a little urinary hesitancy, just to name a few. Sometimes a little blurry vision as well. So those are some things that a patient needs to be aware of. This is a blank slide that has no reason for being there. Oh, can I get this to work? This is the unfortunate part of not being in class. This is an hysterical video by Robin Williams on drugs. I don't know if it'll work on this presentation. No, but I will forward the link on your Brightspace account so you can look it up yourself. Disclaimer, there is quite a bit of profanity in this video, but it really is funny. Contraindications. These are situations that would preclude the use of a drug for a patient, even if they needed that drug in and of itself. A contraindication to any drug would be an allergy to the medication. A contraindication to aspirin would be a history of GI bleeding, because you want to cause more bleeding on top of that. Precautions. All right, so maybe we don't see any contraindications in this patient, but we want to administer or prescribe this medication precautiously. So non-steroidal anti-inflammatories like Advil or Aleve, they can have serious effects in the elderly if they're not prescribed judiciously and maybe for short term. So those are some of the precautions that we talk about. We talked about adverse reactions. These are the intolerable side effects. And remember, we talked about interactions, how one drug can affect the actions of another. Action is how it works. Pharmacokinetics is how it gets distributed through the body. And then we got to worry about if we're giving an appropriate medication to someone who is or may be pregnant. So there is a risk stratification for drugs when it comes to pregnancy from A, B, C, D to X. A means there's been absolute controlled studies, shows absolutely no risk to the fetus whatsoever. Very few medications on the market, either prescription or over the counter, meet that classification. And then it goes all the way down to X, where under no circumstances should this medication be prescribed or given to someone who's pregnant. Something like methotrexate, which they use for rheumatoid arthritis and sometimes tumors and stuff like that, will almost 100% of the time wipe out the baby. So some other terminology related to pharmacokinetics. A biological half-life is the time it takes for half of the drug to be metabolized or eliminated by normal biological processes. That's why some antibiotics you can take once a day, and some antibiotics you have to take every 6 hours, because the ones that you take once a day have a much longer half-life. It takes much longer for the body to get rid of half of it over time than it would be for other drugs. And onset refers to the time it takes for the drug to produce a response. So you want something that works probably rapid, or sometimes you don't. You want something that works at a sustained level. The peak is the time it takes for the drug to reach its greatest effect concentration in the blood. So sometimes in hospitalized patients will have to have blood draws to see when a medication is at its peak, when it's at its highest level, and then they'll have other blood draws to see when it's at its lowest level. And then they try to cater the treatment based on those numbers. And the duration is the time during which the drug stays in the blood at great enough levels to produce a response. The order is the directions given by the provider for a specific medication to be administered to the patient. Now, obviously, you never give, prescribe, administer, or dispense a medication without the direct order from the provider. In reality, well, in theory, the order should always be given and repeated back to the physician and then put in writing or documented before that drug is ever opened or even touched by medical assistant. Does that happen in the real world? Probably not. But remember, when it goes to medication safety and reducing medical errors, you have to understand that if you give a medication wrong, if you either give the wrong medication, either to the wrong patient or the wrong dose, or to the wrong someone who has contraindications, that's an intervention that you cannot undo. It's not like putting a bandage or on the wrong way or splint on the wrong way or or mount not positioning them right way for the x-ray. This is something that once it's done, it's done. So providers should give the patient's name, the health record number, date of birth, reconfirmation, the medication name, dose, and route. So as far as medication orders go, a routine order is medication that can be taken at routine intervals. And this is something that can be ordered ahead of time. A standing order applies to all patients who meet specific criteria. So you might be given carte blanche for standing orders to give someone with a 103-degree fever with no contraindications a Tylenol before the provider has actually met with them. That don't quote me on that though, because that's dependent on the policy and procedures of the establishment that you're working. PRN, and I forgot what the actual letters stand for, but it basically means as needed. So you take a Tylenol, Advil every now and then because you're not feeling well. That's as needed. Whereas a routine order is something like an antibiotic that has to be taken on a fixed schedule. A single order, a one-time order, means the medication is administered just one time. Very common medication would be something like diflucan, which is prescribed for yeast infections. It's a single one-pill dose, which usually one is enough. And a stat order means that medication needs to be administered right now as soon as possible, because that's usually dealing with an emergency kind of situation. So here you got a typical old-fashioned prescription, but the components, whether it be on a handwritten pad or in an electronic health record, still pretty much stay consistent. You want to have the prescribing agencies and the prescriber's name on top with the address, contact number, identification numbers. You want to have the patient's name, address, date of birth, and the date of the prescription. Oh, July 25th, that's my birthday. Okay, that little symbol RX means a subscription. It means what are you actually taking? In this case, they're taking Synthroid, 75 mcgs, which stands for micrograms instead of milligrams. It's a medication commonly prescribed for hypothyroidism. The inscription is the medication and the strength. SIG, that's abbreviation for signature. This is directions to the patient regarding the dose and the timing of the medications. So it says there, 1 tablet, and a little mistake made here, I'll tell you about that in a minute. 1 tablet, take on an empty stomach 30 to 60 minutes before breakfast. So, and dispense 30 tablets. Well, they made it a little bit better there. Prescriptions should never be written with a numeric number. The number should always be written out by word. So instead of the number 1, probably should have been written out as ONE tablet. Because there have been instances, I mean, this is obviously a very well-read, typed prescription, but when it comes to the handwritten ones, there have been incidents where patients may have doctored an extra 0 next to the 1. So instead of maybe 10 Percocets, they tried to write themselves for 110 Percocets. It's been known to happen. So bottom here where it says dispense, they kind of fixed that. So after the number 30, they put the word 30 and refills 0. And again, I don't think I would write 0 because it's very easy to put a 1 in front of that and make it into a 10. Generics permitted. Usually, Synthroid is the name brand of a medication. Most pharmacies will fill a prescription generically unless the physician specifically wants it ordered as the name brand. Very few circumstances where that's absolutely necessary. Some type of anti-seizure medications are important for that, but just so you know, most of the times it will be prescribed generically because it just costs less. So what is your role in prescriptions? Well, in some ambulatory care facilities, medical assistants prepare the prescription for providers to sign, or they put the prescription in the electronic health record. They put in everything, the signature, the dose, the dispense, the number, and the provider either signs it and hands it to the patient or hands it to the MA to hand to the patient, or they review it in the electronic chart and electronically sign it and then press the button to send it to the pharmacy. Obviously, prescriptions that are written have to be written in black or blue ink or computer generated. It can't be written in pencil. All prescriptions need to include the date of time, patient information, everything you pretty much just saw in that previous slide. Provider's full name and address, drug name, drug strength, dosage form, quantity, directions for use, the signature, number of refills. Sometimes patients will call in for refills. Sometimes they'll come in person for refills. Some medications are perfectly appropriate for standing order refills, like some blood pressure medications. Some are not, like narcotics. The National Provider Identifier, the NPI number, is a number that's assigned by the government to any physician so that things like Medicare and Medicaid can reimburse the pharmacies for their prescription. Indicative generic is acceptable. Usually generic is preferred. It's usually the opposite. If by default generic is usually acceptable unless the prescriber checks off a box that says DAW, dispense as written. Now again, the DEA number should be used only on controlled substances prescriptions. So a DEA number, not every provider has one. A DEA number is a certification that a provider has that basically costs a lot of money and permits them to prescribe controlled substances under appropriate circumstances. The NPI number is a national number that is unique to the provider. So if you were to type my name in Google and write NPI after that, press enter, you would see my NPI number. It's just a matter of public record, nothing to hide. But most pharmacies will need that NPI number in order to process any prescription. And of course, be aware of special requirements for controlled substances. So there's been a big to-do about the opioid epidemic and treating chronic pain, over-treating pain, and under-treating pain. That's a subject that's way too broad for us to talk about here, but it's a lot to talk about. So the Centers for Disease Control and Prevention published guidelines for prescribing opioids for chronic pain. I mean, opioids are still an important medical intervention, and they should be used appropriately, especially for patients who are in severe chronic pain. Withholding these medications is basically cruel and poor medicine. But the frequency of opioid abuse means prescribing guidelines are changing. So by law now, most standalone ambulatory care facilities are only allowed to prescribe opioids for 5 days max. Kind of interesting. When I had surgery years ago in my thigh, and I was discharged from the surgery, and I was discharged with a prescription for 100 extra strength Percocets to aid in my recovery. That was about a month's supply. Probably not good prescribing protocol there, but that was before the big boom and surge in opiate overdose deaths we saw in like the late 2010s and 2010s. So for patients who receive opioid care, they need proper follow-up and they need proper monitoring as well. Elderly polypharmacy. If you could take a moment and think about what that entails. The prefix poly means elderly. So as your patients get older, they're going to be more likely to be taking more and more both prescription and non-prescription medications. And the healthcare system in the United States is still not perfected yet, where each entity has access to every other entity. So it may not be common for a patient to get a certain list of prescriptions from their primary care provider and then go off on their own and see an orthopedic doctor for some joint pain and be given a different medication, and then maybe see a cardiologist and be given different medications as well. And none of the three entities may have any idea what the other one's doing. So many times patients are at the elder stages are put on a multiple slew of medications. And even if none of them are copycats of each other, the whole medication interaction situation is something that has to be taken into account. Unfortunately, in my experience, I've seen some instances where that's not been done. Um, so the magnitude of opioid abuse has increased dramatically and considered a crisis. And that's one reason why the management, the procurement, the securing, and the documentation of any controlled substances that kept on your premises has to be meticulously controlled. Now, it says here before patients can get controlled substances, they need to have a urine drug test. That's by no means a legal mandate. That's more of a suggestion than a recommendation. Um, but you know what? At the same time, it's kind of cruel to withhold a known useful pain medication for someone who really does need it. Withholding an opioid is not going to cure a drug addict of their addiction. And prescribing an opioid properly within guidelines is very unlikely to cause an addiction. So many healthcare facilities require that patients receive a printout of their current medications at the end of each visit. One of the responsibilities of the medical assistant while evaluating the patient and doing the intake is to what we call reconcile their medications. Look for the previous charts. Okay, let's see these list of medications. We see a prescription for azithromycin. Are you still taking that? Oh no, that was only a 5-day course. Okay, good. Check that off. Resolve. Atorvastatin for cholesterol. You still taking your atorvastatin? Oh yes, indeed, every day. Lisinopril. You still taking the lisinopril? Yeah, indeed, every day. What's this you're taking? Celebrex. We didn't have that before. Well, that's something your orthopedic doctor prescribed for joint pain. Well, then you need to put that in the chart and make sure all those medications are reconciled. It's important for medical assistants to encourage patients to carry a current medication list in their wallet or purse or some way, shape, or another. It's so frustrating when you're seeing a patient and they told that their doctor is supposed to be taking some medications for their issues, and I was like, well, medication you taking? Oh, I don't know. I left it at home. I was like, okay, really? Can't you just look it up in my chart? Maybe yes, maybe no. But, patient privacy acts sometimes prevent that from happening. If it's within the own healthcare system, like in the Summit system or the Northwell system, may be able to do that. But if they're two completely different systems, then we have no means, no way. All right, if there are any questions, maybe we'll just go over a couple of reviews. No, you can't handle it anymore, but let's try. Which of the following is a source of drugs? Plants, animals, minerals, microbiology sources? And if you said all are correct, you would be correct yourself. The study of drug absorption, distribution, metabolism, and excretion in the body is known as, give yourselves a minute, pharmacokinetics. What's the definition of a side effect? A side effect would be an effect of a drug that occurs in addition to the therapeutic effect. Some may be good, some may be bad. Which organs are primarily responsible for elimination of drugs? Does anybody remember? Yeah, that would be the large intestine and the kidneys, primarily. So the following statements are true. Look it up, look it up, look it up. Intravenous is the quickest way to introduce medication into the body. It is, actually. You inject the medication. It's beyond the scope of the practice of the medical assistant, but by injecting the medication into the bloodstream, it's going to go directly to that target tissue. Taking the medication by mouth or orally, it has to go to the digestive system. It has to go to that first pass metabolism. An intramuscular injection is pretty fast as well, but it still has to diffuse through the muscle tissue before it gets into the bloodstream, and that can take a little bit of time. Upon determination that a stopped control substance is missing from inventory, the medical assistant should immediately Notify the supervisor. Don't take it upon yourself to call the police just yet. Open up all remaining supplies of meds. That'll get you behind bars. And again, don't take it upon yourself to call the DEA diversion hotline. Talk to your supervisor. Document the interactions. Document the conversations. And then go from there. It could be just a simple administrative error. All right, folks, please read up on those chapters because next week we'll be going over the actual administrating and calculation of certain drugs, how to administer drugs through injections, intramuscularly, subcutaneously. It'll be a lot of hands-on. So thank you for your attention.